All righty. Hello, everyone, and thank you for joining us today. Thank you all for joining. It's our first webinar back since June. We've had a bit of a summer hiatus, so I want to make sure you all know that we really appreciate you coming on for our first one of our fall segment, or our second half of the year of our WOC Institute and NSWOC Continuing Education webinar series. We're partnered today with Coloplast. We want to thank them for their support and making sure that we can actually deliver this phenomenal continuing education webinar. Today's webinar is going to be on core considerations, pouching, challenging abdominal anatomy and stoma profiles. And I'm joined today by Melody Yaceyko, who is a nurse practitioner and NSWOC in the Greater Edmonton metropolitan area and is currently employed by Alberta Health Services Edmonton Zone Continuing Care and Vital Signs Health Services, an independent provincial agency provider. Melody earned her nursing degree from the University of Alberta and completed the Canadian Association of Enterostromal Therapies Nursing Education Program. Melody has fulfilled various roles in a home living program, including participating as a member of the short-term intervention team and as an ambulatory clinic case manager. Her current today responsibilities include teaching and consulting in the focal areas of wound, ostomy, and continence management. Now, before we get started, I just want to remind everybody that we are going to be recording today's webinar and it will be available after the fact. And I'm going to encourage everyone from across Canada and even internationally to ask questions throughout the duration of the webinar. At the very end, we'll get to those and we'll make sure that both Melody and I are able to see your questions and sift through them right at the end. Everyone will be receiving a certificate of attendance as well, and you'll get those within 3 days of the webinar completing today. So without further ado, I'm going to pass over the mic to Melody. Thanks, Melody.
Hi, everyone. Thanks so much for your interest and taking the time to join us today. I am Melody, and it's my honor and privilege to be here today. I'm going to go ahead and stop my video. This was suggested you could see my mug, so you know who's talking to you. I'm going to stop the video and go ahead and get started. So it is my absolute privilege to present this topic to you today. Lord knows ostomy management can be super challenging. In my daily grind, hang on, let me see here.
If it's not working for you when you're
nope.
oh, you're good to go.
There
Awesome.
we go. Yeah. The sticky dinosaur key. I was just telling the team here at Coloplast that my computer was an original cast member on the Land Before Time. So let's begin with the courtesy of a disclosure. In my daily grind, I do work with a team of 5 incredibly bright and talented community-based wound, ostomy, and continence nurse consultants in Edmonton with Alberta Health Services. I spent a good bit of time helping to build this presentation in collaboration with this wonderful team at Coloplast. All of the images that were taken from my practice have been used with consent, but the information presented herein has not been reviewed or endorsed by Alberta Health Services. There are many, many commercial ostomy appliances and manufacturers available on the market today, and I do use a wide variety of these in my professional practice. However, with acknowledgement of Coloplast's collaboration and sponsorship of this presentation, this company's branding and marketing materials have been added, and only Coloplast's extensive portfolio of products will be referenced throughout this discussion. I will receive an honorarium for helping to develop and deliver this material. And last, this presentation is for information only. Of course, it's intended to help support best practice ostomy care, but we acknowledge that each patient's circumstance is unique and management outcomes can vary. So professional nursing involvement, including consultation with a nurse specialized in wound, ostomy, and continence management, is always recommended for any person who's experiencing ostomy-related complications or poor appliance wear time. So what are we trying to achieve here today? We know that surgery and stoma creation impacts so many aspects of a person's life, including, but of course not limited to, self-image, elimination, intimacy and sexuality, work and social interactions. The list is virtually endless. It's also an unfortunate reality that many people with ostomies can be challenged by leakage and peristomal skin complications, and these problems are especially prevalent in people who have challenging anatomy or stoma profiles. Fortunately, many of these issues can be addressed or avoided by selecting a well-fitting pouching system with features and accessories, if needed, that are customized to each person's individual needs. So, for the goals of this discussion today, I hope to help promote proactive stoma care by improving your knowledge of ostomies, helping you recognize and manage challenging stomas and peristomal anatomy, expanding your awareness and understanding of the products and resources that are available to support your practice, and hopefully support the ability or your ability, pardon me, to achieve secure appliance seals for your patients and prevent stoma and peristomal skin complications before they occur. If we also manage to help fill your professional tickle trunk with some tips and tools to help correct any existing issues your current ostomy patients may have along the way, well, that would also be a welcome and wonderful bonus. Understanding that we all have different types and levels of education and experience, we'll work to achieve these goals by starting with a quick, and I mean very quick, review of some basic ostomy terms, including principles of basic stoma care, appliance fit, and application tips. We'll touch upon the importance of seal maintenance on health and well-being, and then shift our focus to ostomy assessment and problem solving. Specifically, today we're going to explore how to identify early risk indicators and signs of poor wear by looking at used barriers and sensory signs. Then we'll review some potentially helpful new resources available from Coloplast, including the peristomal body assessment and body check tools to support systematic assessment and problem solving. Here, we'll examine different types of abdominal contours and forms, stoma position, peristomal skin tone and irregularities, and various ostomy profiles. Throughout the discussion, of course, we'll also chat about the function and indications of different types of ostomy pouching systems and select accessories, discuss how these can be used to prevent breakdown and preserve quality of life in people with challenging stomas. Last, we'll close with a very brief summary and hopefully still have a little time left for an opportunity to address any questions that you may have. Once again, thank you all for being here. I'm stoked to be able to share this material with you. So let's begin. An ostomy is a surgically created opening in the abdomen that diverts feces or urine through a stoma, typically created from a segment of living bowel. Stats regarding the exact frequency of ostomy surgery in Canada are not readily available. However, varying estimates presume that about 120,000 new ostomies are created in the US and Canada every year. Stomas may be created in any stage of life, and they're most commonly indicated for management of trauma, congenital abnormalities, inflammatory bowel disease, and cancer. There are three major types of stomas. Colostomy is a surgically created opening in the colon or large bowel. Ileostomy is an opening to the ileum, the small bowel. And urostomy are created by transplanting the ureters into an isolated segment of the ileum and bringing one end through the abdominal wall to create a stoma, to divert urine from the kidneys or bladder. Because they are formed from more distal sections of bowel, colostomy stool is typically more formed and often passes at predictable intervals, such as daily or every other day. Ileostomies, on the other hand, are created from a section of bowel that's much closer to the stomach. Therefore, the output can be quite watery, acidic, and caustic, and usually flows more continuously and at more unpredictable intervals. Urine produced from urostomies also usually flows continuously and at unpredictable intervals. Stomas may be permanent or temporary, depending on the surgical indication or the medical reason that the ostomy was created. With few exceptions, because they lack sphincter control, the vast majority of stomas are managed with a pouching system that adheres to the abdomen and is used to capture the diverted stool or urine, protect and maintain the health of the surrounding skin, and control odor. The basic principles of pouching are really quite simple. In general, they focus on keeping the peristomal skin clean, dry, and protected using well-fitted ostomy products. A pouching system or appliance typically consists of a skin barrier, also called a wafer or a flange, and a pouch in either integrated one-piece or two-piece varieties to contain urine or feces. Disposable and waterproof, an appliance has either a drainable clamp or Velcro closure for emptying, or is non-drainable and closed-ended. Appliance adhesives are specifically engineered to provide a protective seal and prevent contact between stoma output and the skin, while resisting erosion and maintaining the skin's normal pH level. In general, they're also designed to be hypoallergenic and absorb moisture from the skin. Last, these adhesive materials are engineered to be removed without stressing or injuring the skin or leaving excessive residue. All pouching systems need to be changed routinely. These should be removed with care to avoid adhesive-related skin injury. The stoma around the skin should be cleansed with water, and yes, showering is acceptable. After cleansing, the stoma and peristomal skin should be blotted dry. In my practice, I encourage the use of reusable microfiber cloths, the same kind you would use to wash a car without damaging the paint, as opposed to expensive disposable products or towels. And once again, with few exceptions, using soap around peristomal skin should be avoided. Soap can cause a change in pH, promote excess dryness, and contribute to irritation or skin breakdown. Cleansing products that contain moisturizers should also be avoided, as these may interfere with appliance adhesion. In my experience, warm tap water for intact skin or cool tap water if the skin is injured is more than sufficient. Like the rest of our bodies, stomas typically change in size over time. It's very common for them to shrink substantially during the 6 to 8 week postoperative period as the swelling caused by surgery subsides. Routinely measuring the stoma is essential to support a good fit. To obtain the most accurate stoma measurement, the skin around it should be stretched gently so that it's taut. I encourage my patients to measure their stoma at least monthly to confirm they're using the most appropriately sized appliance. Appliance barrier openings should always fit snugly up to the stoma. Up to 1/8 of an inch of space may be left between the barrier opening with a colostomy if there's a high degree of peristaltic movement present. However, leaving even a sliver of peristomal skin exposed to stool has the potential to increase the risk for breakdown, so this should be monitored closely. Allowing a pouch to overfill will also increase weight in the bag, strain the adhesive bond with the skin, and essentially cause the system to fail by pulling it off of the abdomen. To prevent leakage, drainable pouches should be emptied when they're no greater than 1/3 to 1/2 full. I personally will often mark a pouch at the 1/3 point using a felt pen for clients with new stomas to remind them when to empty their bag until they get more comfortable with their system. I can't stress enough the importance of using a correctly sized appliance. In fact, using the wrong size barrier is one of the most common problems I see in my practice because, as we just reviewed, it is typical for a stoma to contract or expand over time. Cut-to-fit ostomy appliances are manufactured with printed rings on the film on the back of the barrier. The outermost ring represents the maximum area that the appliance can be cut to. The right-sized appliance should accommodate the size of the stoma so that it's close to, but does not exceed, the maximum cut margin. After cutting the barrier, if a large amount of space remains between the actual size of the stoma and the maximum cut margin on the flange, the appliance is too large. Continue going down a size. If the stoma exceeds the maximum cut margin, the appliance is too small and a larger barrier is needed. Selecting the most appropriately sized appliance is essential to promoting a seal. Many ostomates think their seal is intact unless they see, feel, or smell uncontained urine or stool coming out from the appliance. This is incorrect. The seal on a pouching system is located at the point where the appliance opening directly abuts the stoma, as it covers and adheres to the immediate peristomal skin. Achieving a reliable seal is one of the greatest challenges in ostomy management. It's dependent upon full contact with clean skin and promoted by using pressure and time. Before attempting to apply a new barrier to someone's clean skin, make sure the area is also dried well. One of the last things I usually do to prep includes blotting the stoma dry because it produces mucus. When mucus from a moist bud squeegees under a snugly fitting flange, this can actually ruin your chance of obtaining a good seal right from the get-go. Pressure and time are equally important for optimal adhesion. Applying pressure on application helps ensure that the barrier comes into full contact with the peristomal skin and adheres to the skin and anatomical contours. Immediately after applying a new barrier, I encourage people to use the fleshy tip of a pinky finger to press on it firmly in a smooth, circular pattern over top of the flange as close as possible to the stoma. Again, this is where the seal lives. This can be done directly over the flange if a two-piece system is used, or over the pouch in a one-piece appliance. This circular technique is preferred to poking along different parts on the barrier. It's generally a more comfortable approach and helps achieve a more uniform tack on the skin. I then typically advise my patients to hold their appliance in place using firm pressure and their own warm hand for just 2 minutes or so. It's important to note that using pressure in this matter has no effect on the ease of removal whatsoever. This strategy does help secure a good seal, but it will not make it more difficult to take the appliance off. There is no specific time recommended for the application of pressure. People should just be encouraged to take the time they need to feel satisfied with the seal. Some find that warming the adhesive before or after application helps, and I've seen all kinds of strategies to achieve this. Microwaves, heating pads, blow dryers, the list is endless. I myself am a fan of just using body heat. Ostomy adhesives typically warm up very quickly and are engineered to perform at body temperature. Once again, in my experience, placing a barrier against the body in a pocket, waistband, or bra cup, which I lovingly refer to as lady pockets, for just a few minutes before a change is both handy and usually sufficient. Once again, the seal is the point where the appliance opening directly abuts the stoma, covers, and securely adheres to the immediate peristomal skin. The moment the stoma effluent breaches this point, the seal is lost. The peristomal skin will be exposed and at risk, and the appliance must be changed. Some of the most common early signs of seal loss include itching, stinging, tingling, or burning around the stoma. Please, 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 please remind your patients that they must never ignore these signs or simply reinforce their barrier with tape if they suspect it's leaking. Failing to change an appliance at the first sign of leakage will trap stool or urine against the skin and exponentially increase the risk for peristomal skin irritation and other complications. Without exception, leaking ostomy appliances must be changed promptly. Appliance leakage is one of the most commonly reported complications of ostomy management. In 2019, Coloplast conducted a study called the Ostomy Life Study. They surveyed thousands of people living with stomas from countries all around the world to better understand the experience of living with an ostomy and how their changing bodies affect ostomy management and quality of life. This work identified significant links between body contours and stoma profiles, and ostomy appliance seal challenges and peristomal skin complications. As a result of this study, it was also confirmed that, to varying degrees, 92% of clients with stomas do worry about leakage. In addition to the peristomal skin problems, when a pouch seal is not trusted or inadequate, additional concerns ensue, such as excessive time committed to ostomy care, damage to clothing, stigmas and social embarrassment, and limited participation in interpersonal and social activities. Without question, confidence and security in attaining and maintaining a pouch seal from the time the pouch system is applied to removal is critical to successful self-management. Achieving a sustained, predictable appliance seal and preventing peristomal skin complications in clients with complex or variable core anatomy is easily one of the greatest challenges I face in my daily practice. Assessment of appliance adhesion and seal integrity begins the moment I meet my client. I like to joke that ostomy management is actually a sensory nursing sport. We know that appliances are engineered to be odor-proof. So if you smell urine or stool, depending on the type of diversion, your client's system is either externally soiled, open, or leaking. Simply scanning a person's dressed abdomen can also provide potential clues to the problem. As you see in this image, this client's jeans are transecting her abdominal pannus below the level of the stoma. Not only does this look uncomfortable, but it puts her at risk of having her clothing shear off her pouch, or potentially worse, obstruct blood flow or output the stoma. One of my go-tos, and one of my colleagues' go-tos, as this was her client, is to suggest that women with stomas consider wearing low-rise bottoms or maternity pants with integrated stretch weave belly panels. Be prepared, most ladies will typically be quick to scoff at the idea, but maternity fashion has actually come a long way, and many of today's styles are actually super cute and very comfortable for ostomates. When assessing a client with a two-piece pouch, I see many nurses take the whole system off all at once. I do not. I intentionally take off the pouch first so I can examine the fit and seal integrity of the client's old barrier before it's removed from their abdomen. As you can see here, this flange has an overt gap between the 6 and 9 o'clock positions that aligns with the slightly downward facing lumen, or the os, mouth, or opening of this stoma. In this picture, it points down towards approximately the 7 o'clock position. The ideal location for the mouth of a stoma is central, right smack dab in the middle of the bud, so that when that stool moves, it's projected directly into the collection system. When the os is offset or tilted, the barrier margin nearest this point typically fails prematurely as a result of continuous exposure to output, especially if it's liquid, caustic, or expelled with force. A quick solution when you see a directional opening like this is to apply counterpressure on the opposite side of the stoma before adhering the appliance. For example, before adhering the next barrier, I would pull the skin around the stoma taut and using my index finger, apply gentle pressure at the edge of the stoma opposite the lumen, indicated by this green dot, at approximately the 2 o'clock position. This should cause the mouth of the stoma to rotate in the direction of the counterpressure that's being applied. Adhering the flange while the lumen is rotated into this position should help stabilize it and keep it more central. Alternatively, or in addition to the use of counterpressure, convexity can be used to help improve the seal, but we'll talk about convexity in a moment. Last, I'd be remiss if I didn't point out that we also see a room of exposed skin around the edge of this barrier opening, suggesting additional education and support may be needed to improve the fit. In addition to looking at the front of the old barrier, I also look at the back after it's removed to assess the wear pattern. All flanges will typically swell as they absorb moisture at the junction where the stoma abuts the opening, a phenomenon referred to as turtlenecking. When a seal is well maintained, you should see a uniformly swollen turtleneck pattern, extending 360 degrees around the opening, similar to the pattern seen on the first half of this barrier, where the seal was actually intact. The other half of this flange, however, shows a swollen but irregular pattern of erosion, evidence that the seal was compromised on this half of the barrier before the appliance was removed. This reinforces the concept that the moment effluent breaches the skin to barrier junction, the seal is broken. Typically, this erosion pattern will also mirror a pattern of skin injury caused by effluent being trapped against the skin under the barrier. It's also important to be mindful that the skin around the stoma should always look like the skin on the rest of the abdomen and be free of any lesions of any kind. Although identification of peristomal skin abnormalities is not the focus of this presentation, the location and patterns of skin injury can be helpful in determining the most common location of leakage and strategies to prevent it. In this image, for example, we see a very symmetrical linear area of breakdown resembling an oval shape around the stoma. This pattern suggests that while the seal is otherwise well maintained, the client's barrier is being cut to both the wrong size and the wrong shape, leaving the skin consistently unprotected and causing it to break down. To correct this problem, I'd reinforce education on how to measure and size an appliance correctly. I'd also apply a layer of hydrofiber to the broken injured skin to absorb drainage, apply a rim of liquid paste, and continue to use the client's existing ostomy appliance. I'd also recommend changing the barrier more frequently until this skin is closed. In this image, we see early signs of peristomal granuloma formation with inferior excoriation, or kind of the red rashy area at the bottom of the stoma. Likely because, this suggests, that the entire margin of the stoma has been exposed to moisture, likely because the appliance is being cut too large or being left in place for too long, and leakage is pooling under the barrier against the skin at the bottom of the stoma, where gravity tends to pull it. Unlike the previous example, however, the unfortunate profile of this stoma and irregular core anatomy make this a much greater challenge to manage. Here's another barrier with an abnormal erosion pattern, but the problem here is pancaking. Pancaking occurs when, instead of dropping into the pouch, stool accumulates at the stoma and seeps under the base plate, compromising the seal and the risk for peristomal skin breakdown. There are several contributors to pancaking, including, I just completely lost my notes, folks.
Did you want, we can just try sharing the screen again if you want.
Pardon me?
If you want to try just closing the PowerPoint, then resharing again, maybe they'll pop back up for you.
Okay. I will do that. Give me 1 minute.
No problem. I'll just
Isn't
take
this a
the
Murphy's
opportunity
Law?
now.
Isn't this a Murphy's
Well,
Law type situation?
oh, totally fine. Again, it's been a couple months since we last had our last one, so I'm hoping everybody's excited to be back together here. I'll take this opportunity to remind everybody that we will be taking questions, of course. So if you have any questions at this time, or if there's anything on your mind, feel free to pop those into the Q&A toolbar or the Q&A button in your toolbar there, and we'll make sure to get to those at the end.
Okay, wish me luck, folks. Oh, thank you, Beth. That's lovely. Little words of encouragement. Sweet goddess. Help me,
You're getting
help me.
tons of emojis popping up here too, so you're doing okay.
You guys are
Is
feeling
there
me. Such positive energy. I love it.
And if they're not, the notes aren't popping up for you, we can always ask a cashier in the background might have the notes in the PowerPoint too. So just let us know if you want us to call an audible.
Mm.
Yeah, I can share the presentation, Mel, and you can access the notes on your end if that works.
Let me give me 3 seconds here. What was that dinosaur's name? My little dinosaur is working hard. Gosh, the worst thing happened. You predicted it. I live in the country, folks, and so my service is so my service can be patchy. So you press in the middle of the flange after the stoma bag has been applied for it to seal properly. Yeah, actually, good clarification. Good moment to clarify. What I mean by applying gentle circular pressure is after the barrier's in place or after the pouch is placed, you're going to use a pinky finger and just trace around the rim of the barrier that is closest to the stoma. That should typically make everything adhere much more readily and improve tack around the skin or on the skin around the stoma, much like you reinforce Scotch tape when you really want it to. Littlefoot was the dinosaur. Much like when you reinforce Scotch tape when you're trying to get it to stick to a Christmas package. Okay. I think, can you guys see me?
We can see it looks great, and you will not. I don't think we had a test at the end of this, but it's good to know that we have a lot of Land Before Time trivia gurus in the background here.
I love that. All right. So I was just about to talk about pancaking when the higher power that controls electronics struck me down. So let's start. Here's another barrier with a normal erosion pattern, but the problem here is pancaking. Pancaking occurs when instead of dropping into the pouch, stool accumulates at the stoma and seeps under the base plate, compromising the seal and increasing the risk for skin breakdown. There are several contributors to pancaking, including constriction across the top of the appliance, usually from clothing, waistbands, belts, or pantyhose, for example. It is always advisable to ensure all clothing, seatbelts, uniforms, equipment of any kind are adjusted to accommodate the stoma location in order to ensure stool passes through it freely into the pouch. Commercially prepared stoma guard devices are all now also widely available for online purchase if the source of a constriction can't otherwise be alleviated. Prolonged lying in a supine position or flat on your back where gravity makes it more difficult for stool to be ejected into the bag might be another cause. And in this case, we would try to improve the frequency of repositioning and rotating periodically from back to side, etc. If the pouch walls adhere to the stoma, sometimes this can create a vacuum type effect that prevents the stool from moving through the appliance and may be a contributor as well. Or, as is obviously the case with the example seen in this image, constipation. When a client's stool is very, very firm and constipated, the lumen of the stoma has to dilate significantly in order for it to pass the stool, much like a cervix has to dilate from its normal size to pass a baby. So this is problematic because the flange is fixed and can't dilate, and it's cut to size. So as a result, the barrier usually ends up being pushed upward and stool is typically squeegeed under it. The best solution, of course, to this problem is to correct the cause, which is constipation. I encourage you always to review diet and hydration with your patients, and where appropriate, encourage them to discuss the possible need for a bowel routine with their most responsible prescriber. And a bowel routine typically involves fiber therapy, stimulants, softeners, that kind of thing. Last, if my patient's stool is not necessarily firm but somewhat sticky, and I presume that this is the reason that it's not sliding through the system effectively, I'll offer a lubricating deodorant, such as Coloplast's Brava brand. This product does exactly what the name implies. A few drops in the pouch help to neutralize odor and lubricate the walls of the bag to prevent stool from adhering. Oh dear. Okay, we're back. The guiding principles of ostomy management are quite simple, and we now know how to identify signs of both subtle and overt leakage. And it's that piece in the middle, though, figuring out how to achieve and maintain an ostomy appliance seal, that can be incredibly challenging, and here's why. Our human bodies are dynamic. We change continuously with weight gain or weight loss, with growth and development, progressive aging, and other factors, fitness, activity, nutrition, disease, and injury. There's so many reasons. No two bodies are perfectly alike. And as you can see in the images depicted on this slide, it's a common thing for people to end up with vastly different and challenging core anatomy and unusual stoma profiles. There are just no one-size-fits-all quick fixes in ostomy management. Fortunately, some wonderful new clinical resources are available to help clients and clinicians meet this challenge and support a good seal. Among these is Coloplast's peristomal body profile assessment tool. This tool was developed through a consensus process involving more than 2,000 ostomy nurses across the globe, including Canada. Using standardized terminology, this tool can be used to help consistently assess and describe different body contours and stoma profiles, understand an individual's needs and how their unique and variable anatomy may affect wear time, and systematically help address these needs through the curated and intentional use of ostomy products and accessories. The peristomal body assessment characterizes anatomy according to abdominal contour and variability, texture, peristomal skin irregularities, and the location of the stoma and its profile. Each of these categories is then further refined into 15 subcategories, shown here, to ensure each person's unique anatomy is fully captured, and it allows for up to 648 different profiles. Building off of this international consensus work, Coloplast has also developed an online body check tool. Oops. There we go. This is an interactive program. It helps guide people through each step of the assessment and helps characterize their unique body profile. Most importantly, the body check tool then processes the inputted data and offers a suggestion for pouching solutions to address the needs for fit and potential challenges indicated by that person's unique anatomy. It's a super cool tool. Both tools can be accessed using the QR codes on the screen. You can screenshot them and load them into a smartphone later, or you can access them now using your smartphone camera. If needed, you can also reach out to your Coloplast representative after this webinar if you prefer to have these resources emailed to you directly. Now let's go through the steps. Oh, let's not go through the steps. Let's look at metrics. Let's look at our motivation for using these tools. After these tools were implemented, evaluation metrics performed by Coloplast showed that using the structured approach in the peristomal body profile assessment tool allowed nurses to reduce the average number of weekly leakage episodes in the cases that were followed from 5.9 to 1.8 after just one consultation. Not surprisingly, improvement in quality of life indicators, including emotional impact, coping, and socialization, also coincided favorably with the resulting reduction in leakage. This data does demonstrate good motivation of the value of the tools and good clinical care. Nurses were supported in finding the most appropriate product for the patient and significantly improved quality of life. The first step, now let's move through the tool, of the peristomal body assessment asks the user to qualify the form of the area around the stoma. Is the peristomal area more or less level with the abdomen? Does it sink into the abdomen, or does it rise above the abdomen? For example, people whose peristomal margin is more or less level with the rest of their abdomen are considered to have regular body profiles. These people may or may not require convexity or need accessory products to maintain a sustained, predictable appliance seal, depending on the size and silhouette of their stoma, peristomal skin condition, and other variables. Convex appliances are curved or bowl-shaped. Convexity can be used to flatten peristomal skin folds or creases, or help to pop a stoma by increasing its protrusion above the level of the skin and promote more direct discharge of the stoma effluent into the pouch. Convex barriers and accessories increase pressure over peristomal skin and tissue proximal to the stoma to help preserve and maintain the seal. They vary in shape, depth, and rigidity. Coloplast offers soft, light, and deep convex options in a plethora of pre-cut and cut-to-fit sizes to support virtually any stoma profile or add support for clients with challenging peristomal skin tone or other core anatomy. When fitting a client for convexity, it's important to match the size of the stoma with the size of the convex plateau or the raised area. This is such an important point. The effect of convexity is optimal when it's applied as close to the mucocutaneous junction as possible. If you're unsure of what level of convexity your patient needs, Coloplast also has developed a convexity decision guide for compatible use with the body profile assessment tool. For ease of reference, you can access the convexity guide by using this QR code. I'll just pause for a beat if you'd like to take a screenshot or load it into your camera. But once again, you can also reach out to your Coloplast representative anytime you'd like the resource emailed to you. In this example, we see a peristomal skin contour that sinks into the abdomen and creates a moat-like dip around the stoma. This lady has an inward body profile. For people with inward body profiles, convexity helps fill the circumferential dip and encourages the stoma to pop towards the pouch. It can be challenging to do, however, while still preserving comfort and flexibility. So in my experience, the most appropriate way to achieve this is by ensuring the size of the convex barrier is correctly matched to the size of the stoma. This tip bears repeating because it is so incredibly important. Convexity is most effective when the apex, or the highest point of the bowl shape on the flange, sits as close to the mucocutaneous junction as possible. The wider the convex plateau, or the farther it extends away from the stoma, the less effective it becomes. It's again also relevant to note that convex barriers offer varying levels of depth, rigidity, and flexibility. That's why we have that decision tool. Manufacturers, including Coloplast, are constantly working to update and improve their product lines and prioritize seal, security, comfort, and quality of life. Recently, for example, the Centura Mio Convex has been re-engineered with BodyFet adhesive technology and integrated flex lines. Basically, these are impressions that are carved into the barrier material, much like slits in the sole of a running shoe, to provide improved flexibility without compromising stability at the foundation of the stoma. Outward body profiles are those where the area around the stoma projects outward from the abdomen to form a peak. Increasingly, studies have demonstrated that lifestyle may be an important target to improve outcomes for people with this type of stoma profile. Lifestyle factors such as diet, physical activity, and smoking have been associated with stoma-related complications and are considered important for overall health, well-being, and mortality. Not surprisingly, this profile correlates highly with being overweight or obese. One of the most common types of outward abdominal profiles I see in my practice, however, is associated with peristomal herniation. A peristomal hernia presents as a bulge or bump, usually with a defined palpable margin at the base. Peristomal hernia is an incisional hernia at the stoma site. They occur when additional intestinal tissue protrudes through the muscle layer that's been opened to create the stoma. The incidence of peristomal herniation is as high as 50%, according to some estimates, and this can increase over time. Symptoms of peristomal herniation may include aesthetic complaints, discomfort or pain, appliance leakage, difficulty fitting appliances, bowel obstruction, incarceration, or even perforation. If your patient has a peristomal hernia and is experiencing abdominal pain, lack of stool output or vomiting, or if the stoma is bluish in color, which could indicate that the circulation is compromised, they should see a physician immediately. Key nursing strategies for the prevention of peristomal herniation include, but aren't limited to, patient education on modifiable risk factors, including obesity, malnutrition, exercise, smoking, and constipation. It's interesting to note that this type of hernia is the most common stoma-related complication that requires surgical intervention. Non-surgical management of peristomal hernias usually involves the use of flat, flexible ostomy appliances with or without flange extenders and peristomal hernia belts. Coloplast offers Brava elastic barrier strips in a variety of shapes and sizes to support customizable care for every abdomen. Registering yet another ostomy innovation, Coloplast also offers an additional seal strategy for clients with outward abdominal profiles, a concave barrier. All of Coloplast Centura Mio products, including the concave version, incorporate BodyFit technology, a unique proprietary elastic adhesive that supports secure contact for seal integrity and peristomal skin protection, and flexible fit during movement. This smartly designed shape conforms to and cups the curve of an outward abdominal contour to resist peripheral peeling, seen with many standard flat barriers. It grips the abdomen or cups it. The petal-shaped design also helps prevent creasing and folding, while the integrated center ring supports and stabilizes the stoma to limit mobility and preserve the seal. If you haven't had an opportunity to trial a concave appliance yet, it's a worthwhile addition to your toolkit. The second step in the standardized peristomal body assessment tool asks the user to determine whether the area around the stoma is uniform or variable. When you look at the area around the stoma, is the right side different from the left? Is the top different from the bottom? Or do you have a consistent appearance across the area? In this example, we see that the peristomal contour is highly irregular, with a deep dip present at the inferior aspect of the stoma. In this case, I'd likely recommend using a flat or soft convex flexible barrier with a bead of liquid paste applied sparingly. Like many of my NSWOC colleagues, I continuously reinforce messaging that although the word paste is synonymous with glue in many other circumstances, it's not the case here. Ostomy paste functions more like caulking. It helps to fill creases and prevent liquid effluent from seeping under the base plate when it's freshly applied. In my experience, when it comes to ostomy paste, less is definitely more. Note whether or not the paste you're using contains alcohol. It could cause burning if it's applied to a freshly sutured stoma or injured skin. When using paste containing alcohol, consider putting a bead on the back of the barrier and then allowing it to sit for a few minutes prior to application to the skin so that the alcohol has an opportunity to evaporate. Alternatively, many companies, including Coloplast, offer ostomy paste in regular and alcohol-free versions, such as the Brava line seen here. Brava alcohol-free paste offers all of the seal-preserving benefits of regular paste in a pH-balanced, no-sting formula. In step 3 of the tool, we ask the user, is the abdomen soft or firm? When it's soft, it means it yields under pressure. To illustrate, try touching your index finger and thumb together, then press the ball of your thumb. That's the way a soft abdomen will feel. A firm abdomen will feel more like when you're pressing under your heel. Assessing abdominal tone is particularly important for helping determine the best barrier shape for your client. In most cases, any level of convexity can be used on a person with a soft, pliable abdomen without cause for concern. If a deep convex barrier is used with someone on a firm belly, however, problems like this can occur. This image shows peristomal pressure injury and ulceration related to the use of a deep convex system on a hard tummy. This healed quickly once we treated the ulcer and switched to a flat flange. Step 4 of the peristomal body assessment tool prompts the user to consider whether there are any superficial or deep irregularities around the stoma. Here you would look at the creases around the stoma. Are they superficial or are they deep? Are they skin folds? In this example, the client's skin folds are so deep when she's seated in the seated position that her stoma virtually disappears. She needed a deep convex appliance and belt to help stabilize and support her stoma under the weight of these mobile folds. In this next example, we see a lady with moderately butted ileostomy complicated by significantly mobile pleated drapes of peristomal skin. When I place the flat palm of my hand on her tummy, it moves in a circular motion and her skin is not at all fixed. It moves freely with my hand. It's a common phenomenon in many post-op ostomy patients, particularly those who are elderly, when the perioperative experience results in considerable and rapid weight loss. But the lack of a firm peristomal foundation also makes it difficult to create a reliable seal. In cases like this, I typically opt for paste and a light convex barrier. I find that if effluent is still escaping the seal due to the depth of the proximal creases, I may consider also applying strip paste. Strip paste is an excellent filler material for deep folds and creases. This product helps create a smoother peristomal plane to achieve a tight seal between the skin and the barrier. Brava strips are also highly conformable, hypoallergenic, moisture absorbent, and resistant to breakdown. To apply, you simply tear off the length that you need and mold the material into place. This is an alternate pediatric client. I saw this child with one of my NSWOC colleagues. Initially, it was thought that the baby had developed a peristomal granuloma. The area was raised approximately a half centimeter above the level of the rest of the skin on the abdomen. It had been treated a few times with silver nitrate, but it appeared to make the lesion worse, not better. On closer examination, it was evident that this was not likely a granuloma caused by contact dermatitis or chronic medical adhesive skin injury from continuous changes, because the skin between the stoma and this lesion was actually intact. So it was implausible to us that this problem was caused by contact with effluent. With acknowledgement of the child's age, skin color, and ethnicity, I asked the baby's parents if either of them had ever developed any kind of keloid scarring from previous injuries or surgery. His dad proudly held out his arm and lifted his sleeve and asked me, "Do you mean like this?" So scarring can cause either inward or outward deformations on peristomal skin. Specifically, a keloid is an elevated fibrous scar that attends beyond the borders of the original wound, does not regress, and usually recurs after excision. They also usually form later than standard scar tissue, typically at least 3 months after the initial injury. Acting on this differential diagnosis, my colleague recommended the use of ostomy powder to absorb moisture and reduce irritation. We also covered the lesion with a very small piece of silicone mesh to reduce trauma associated with appliance changes, and within a few weeks, although it was still slightly elevated, the scar had reduced significantly and was no longer causing the baby pain or contributing to seal problems. Step 5 wants to know, where is the stoma located? Is it above the bending line, at the bending line, in which case you'd see creases typically at 3 and 9 o'clock, or below the bending line? Here, it's important to understand that the bending line and pivot points are two different things. A pivot point is at someone's hips, but we never actually bend at our hips. We typically bend higher up, so the bending line can be higher up than the pivot point. If a stoma is located at or below the bending line, you can consider using a belt to stabilize the appliance and ostomy paste to fill creases and create a flat surface that the barrier will adhere to. While I was reviewing literature for this presentation, I found a really interesting European dermatology paper reporting on a novel approach for treating peristomal skin creases by injecting them with medical-grade fillers, including porcine collagen and polyacrylamide hydrogel. Although only 8 case examples were presented in this paper, I thought it was a really innovative solution that may be worth some consideration down the road, given the right circumstances. This image you see on the screen is a client who might benefit with that treatment in the right circumstance. Alternatively, where the deep fold is observed, I might try leveling out the abdominal plane by filling it with strip paste or a wedge of barrier ring, and then apply a light or deep convex barrier, depending on how soft her abdomen is, paired with a standard ostomy belt. Most barrier rings or seals are circular and manufactured from a hydrocolloid similar to that of the back of a skin barrier. Brava protective rings are made from a proprietary polymer that fills deep defects and resists erosion while leaving very little residue behind on the skin. They are also available in a wide variety of widths and thicknesses and readily customizable to your client's needs. Like strip paste, barrier rings are generally hypoallergenic and pliable, but durable, making them a valuable accessory in my toolkit when dealing with complex stomas. An ostomy belt attached to a convex barrier. Oh, wrong slide. An ostomy belt attached to a convex skin barrier can also help the skin barrier adhere to the abdomen and prevent leakage by increasing tension around the stoma, specifically at the belt loops at 3 and 9 o'clock position, or in this case, just slightly below that. Over the years, I've had many clients relay the sentiment that their ostomy belt is like their security blanket. Most of them don't like to leave home without it. Step 6 in the assessment tool asks, what is the position of the stoma opening in relation to the surface of the skin? Is it above the skin level where it protrudes? Is it level with the skin, or is it below the level of the skin? Ideally, a stoma should be budded and protrude about 1 to 3 centimeters above the level of the skin. Because the stoma is constructed of bowel mucosa, and this mucosa contains many small blood vessels, a healthy stoma should be dark pink to red in color. This dense vascularity is also why a healthy stoma might bleed slightly when you clean it. It's normal, provided the amount of blood is small and the duration of bleeding is very brief, temporary. Because the surface of the stoma is a mucous membrane, it should also be warm and moist. To the touch, the stoma should have tissue consistency similar to your lips. In my practice, a normal, healthy, budded stoma is like a leopard-spotted unicorn. We're only consulted when problems arise, so we almost never get to see them. You want to sit with me and pause and gaze and admire? Just kidding. We've got lots of work to still do. This little fellow, on the other hand, feels like an old friend. This is a prolapse stoma sitting proudly atop a hernia. Prolapse occurs when extra bowel tissue protrudes through the opening created for a stoma. It's most common in loop stomas and in ostomy patients who have weak abdominal musculature, including the extremely young, the elderly, and those who are malnourished. If the bowel tissue is pink to red and moist and the stoma is functioning well, a prolapse is not really an urgent situation, but they can be difficult to manage. It's typically easiest to apply an ostomy system to a prolapse stoma when the client is laying supine on his or her back. This position helps reduce the prolapse so it's less prominent, as gravity causes the bowel to fall back into the abdominal cavity. If it does not reduce naturally, reduction may be encouraged by applying a cool, moist cloth to initiate vasoconstriction, or by applying hyperosmolar sugar or honey to reduce moisture in the exposed bowel, which will cause it to shrink. Postoperatively, most ostomy patients are fitted with flat skin barriers. Normally budded stomas with uncomplicated core anatomy can usually be managed effectively with this type of system. Flat barriers are also the mainstay of prolapse management. Any product that increases peristomal skin tension should be avoided, as these may exacerbate the problem and make the prolapse worse. On the opposite end of the stoma profile spectrum, a flush stoma, like the one seen here, protrudes only to the level of the skin. A stoma that is indented or set below skin level is referred to as a retracted stoma. Flush or retracted stomas may result from tension on the stoma because of obesity or abdominal distension, mucocutaneous separation, stoma ischemia and sloughing, or extreme weight gain after surgery. One of the most common seal strategies for poaching flush and retracted stomas is the use of a convex barrier with or without an ostomy belt. Now that we've covered our priority assessment topics, let's examine some cases taken from my practice. This very lovely man has a tiny ileostomy above the belt line on the right side of his abdomen. I assessed him in clinic for reports of inability to maintain a seal. He was leaking all the time. In this position, laying flat on his back, his stoma appears flush, possibly a regular abdominal profile. He's not overweight or obese. His abdomen is soft and non-tender with no palpable masses. Only mild peristomal skin injury is evident. His output is continuous throughout the day and ranges between semi-formed and liquid depending on what he eats. When our friend stands, however, we appreciate the full impact of his skin tone and abdominal profile. He has an inward profile with heavy draping skin folds that roll over his ostomy site. I immediately switched him from his hospital-initiated flat barrier to a deep convex flange with alcohol-free paste and a standard ostomy belt with a good effect. We also used ostomy powder for a very short term, less than a week, to help heal his injured peristomal skin. Here's another client of mine. This lady also has an ileostomy located just above her belt line. While awaiting her first home visit from the community nurse, she had reinforced her leaking barrier with paper towel, resulting in substantial skin injury across her abdomen. This tissue is very soft with no palpable masses, but it is quite tender. In the laying position, she appears to have a proud, well-bedded stoma with proximal dips and creases, and this is confirmed when she assumes a seated position. Her stoma is definitely well-bedded, but the presence of very loose, heavy, mobile skin is likely compromising the foundation of her appliance and disrupting her seal. Her abdominal profile continues to peer inward. So this is once again confirmed when Our Lady assumes a standing position. Her seal strategy involved filling the dips at the medial and lateral edges of her stoma with wedges of barrier ring and applying a deep convex barrier with a sparing bead of alcohol-free paste, followed by a standard ostomy belt. Although this case was not taken from my practice, it's a lovely example of an alternate core abdominal profile. While laying flat on her back, this lady appears to have a regular contour, but don't be fooled. Once again, this is just gravity causing her internal organs and stoma to relax and fall back into her abdomen. When she sits upright, we clearly see that she actually has an outward profile due to what appears to be a peristomal hernia. In this case example, a concave barrier was trialed with good effect, and I'm told the client was very satisfied and intends to continue with this pouching system. Her trust in the security of her seal was remarkably increased, and she reports that she was able to achieve a predictable wear time of 6 or 7 days without leakage. And her peristomal skin erosion improved with the added, very short-term use, once again, of the addition of short-term ostomy powder. If she were my client, I might also encourage her to use a peristomal hernia truss, which I'm sure they did, in order to help control the hernia, improve her aesthetic, and prevent potential hernia-induced complications, such as lower back pain. So here we are at our summary. It's nice to pause and just acknowledge that the initial phase of a new ostomy can be overwhelming for patients and caregivers. To build everyone's confidence, we work closely together to try to build trust. It's consistently been my experience that even the most seasoned ostomate is capable of feeling defeated when their appliance wear time is poor or unpredictable. My best advice is to commit to the collaborative process of assessment and problem solving and use all of the resources that are available to you. It's my hope that the assessment skills we reviewed today will help support decision-making regarding preventive ostomy management and peristomal skin protection. The key lies in identifying irregular core anatomy and how to mitigate this using assessment tools and techniques and appropriately fitted products. Please, please, please educate your clients and families and champion their independence with ostomy self-care. Last, always remember to reassess in a timely fashion, especially when introducing new strategies, products, or accessories. I just wanted to take a quick minute to just share some of the published data that supports the use of the peristomal body profile assessment tool. And of course, as promised, well, not promised, I don't represent that I am a goat, but I do have a goat. Actually, I have 2 goats. This is Eleanor. And now, if you have any questions, I'd be happy to speak to those.
Amazing. Well, first of all, that is super cute. Love that you have goats. That's great. Between the little foot references and the goats, we have a very cute and heartwarming presentation today. But no, but seriously, that was fantastic. And I know just from the comments we've seen in the chat here, from the questions we've been getting, that everyone else here also appreciates that. So thank you, Melody, for a great presentation. We are a little bit over time here, but I think we can get to maybe 1 or 2 questions because I know we've had some good ones. I know in the background there, Natalie's been helping out with some of them. So the first question I was going to just quickly ask, and I know, not sure if Natalie addressed this, but we'll talk about it for a second anyways, is what are some recommendations you might have for managing wounds near the stoma under the flange, especially in cases of pyoderma gangrenosum?
Hmm. Yeah, I love for pyodermas, I love using silver hydrofiber. The reason for this is because pyodermas are highly susceptible to infection. They're exquisitely painful. So a hydrofiber, once it gels, is typically very atraumatic to remove and doesn't contribute to pressure. And by nature, hydrofiber is a vertical wicking material. So as it absorbs drainage, instead of allowing it to seep under the flange and cause it to lift prematurely, you can add a couple of layers on top of each other under the flange, and it will absorb before it starts to seep. So silver hydrofiber, definitely one of my go-tos. And I know I have a colleague, Nancy Moody, she absolutely used that with great success on one of the most significant cases of PG that I've ever seen.
Okay, well, thank you for touching on that. And maybe we'll get to this question for a second here. Christina's just asking, do you know that if it's normal for an end colostomy to retract and turn pale after a temporary loop ileostomy is created? So a little bit more specific here, but have you come across that before?
Yeah, there's a number of reasons why a colostomy is super mobile. My initial thought is if it's moving, it's living. So if it's retracting and then coming back out again. So if it's really demonstrating good peristaltic motion, I wouldn't be too concerned with color changes. Often what happens is when the bowel contracts, blood is squeezed out and it looks a little more pale. And then when it relaxes, the blood comes back in. Great rule of thumb, it's not typically a problem if it's active. So the most important question is this stoma active? Is the client having any pain, any signs or symptoms of infection, any fever, and is that stoma active?
Perfect. Thank you. Okay, well, maybe we get to just two quick ones here. Okay, so this one here is on urostomies here. What are some good strategies that you would use to prevent leakage with urostomies, especially if the stoma is flush or retracted?
Yeah. So I've had a couple of really innovative clients do some pretty cool things. So I had a client use a section of hose, another one used some PVC conduit, and so with a retracted or flush urostomy, if you put gentle pressure with a tube over top of it, it will collect urine. And because the tube is sized to the same size as the urostomy, you can slide the pouch over top of it. I like a little bit of paste myself with urostomy, but that's one of the strategies that I've seen work really well. There are also a number of different products offered across the panorama of ostomy products that work really well, such as stoma collars or barriers that are made of an alternative, something that's not necessarily CMC. So if you continue to have challenges with your ostomy, that might be a case where I would definitely see if I could track down an NSWOC and see if she can take a look and bend her ear. Or he. That was super sexist. Sorry, gents.
All good. The next question here, maybe we'll end off on this because I know we've had quite a few, but I know Natalie's in the background answering some of them. Could you provide any insight or advice for someone who might be dealing with two stomas, especially if one is developed after the initial surgery?
Yeah, two stomas is really commonplace in our practice. My best advice is to take your patient's temperature. And by that, I mean, how are they doing? What's the indication for the stomas? Typically, that whole psychosocial assessment piece that comes with comprehensive ostomy management will help you. But there is generally no reason why following this assessment tool for each individual stoma is not a good idea. In fact, it's a great idea. Just enter the details. Say if you have a urostomy on this side and a colostomy on that side, enter the information for each individual stoma, and you may be surprised. You'll likely come up with very different pouching systems for each appliance, or for each stoma, sorry.
Perfect. Okay, well, just to answer some of the other background questions here, everyone who has attended live today, you will be getting a certificate of attendance, so no worries there. For anyone who's looking for those QR codes or links or wanted to look over some of those slides that were presented today, you will get the recording of this presentation. We'll be sending it via email. You can also always find it on our nswoc.ca website under our webinars area, so you can definitely go back and check that out. We should have it up within the next day or two, so we'll make sure to send an email to everyone who was on today. But just so you know, you're not going to be losing access to that. And I'm sure behind the scenes here, our friends at Coloplast, if you have any questions, you can always get in touch with them. They should be able to follow up with an email as well. So with that said, I want to thank you again, Melody. What a fantastic presentation. I know you got through a lot in such a short period of time. So really appreciate you sharing your expertise. And I hope it's not the last time we'll have you on board with us.
I just want to thank you all for your patience, and I want to apologize for my poor little foot glitch, but hopefully next time I'll have some better equipment. You guys are great. Thanks for your energy and your questions. It was truly my pleasure to be here. And thank you, of course, also to the team at Coloplast. Excellent clinicians and resources for your ostomy needs.
Amazing. Okay, well, thank you, everybody. Have a great night. And if you have any questions, you can always get in touch with us at office@nswoc.ca. We'll always be ready to get in touch with you. Thank you again, Coloplast. Thank you, Melody, and have a great night.
Thanks, everyone.